Good morning, everybody. I would like to welcome all our foreign delegates. It's my pleasure to have you, all of us here. We would like to commence the Bridging Gaps in Oncology Congress, which is a conjoint meeting between the NCI, Cairo University, the Mediterranean Multidisciplinary Oncology Forum, MOF, and the Egyptian Cancer Society. Professor Demir, the president of the MOF and the Turkish Oncology Society, I would like to welcome you. Professor Van Berbek, it's our pleasure to welcome you here. Unfortunately, Professor Mustafa Serfi, who was supposed to chair this session with us, is a little bit sick, so I hope that he will be well, and I apologize that he's not able to come today, this morning. We have all of us worked hard to produce an excellent meeting that we hope that it may meet your expectations. Professor Rabab, which I'm glad that she presented the meeting. Please, Professor Rabab.
Good morning. I have the honor to introduce Professor Paris Cosmides, Professor of Medical Oncology at Gezira Hospital in Greece, and past President of the European Society of Medical Oncology. His talk will be on a very important topic, which is the role of immunotherapy in non-cancer promises and challenges. Professor Cosmides, please.
Chairpersons, thank you very much for this kind introduction. I'm really honored to participate in this excellent Congress in this beautiful and historic city of Cairo. I remember very well as an ESMO president 10 years ago, working perfectly well with our Egyptian colleagues, having together meetings and trying to make oncology more visible, both in Europe, in Egypt, and worldwide. My topic today is the role of immunotherapy in lung cancer, which is really one of the latest achievements that we have in treating cancer. Which are the major steps in treating cancer so far? Surgery, radiation therapy, chemotherapy, and lately targeted therapy. What have we achieved with this type of treatments? I think that we have to accept that we are not very proud about our achievements regarding the 5-year survival in advanced disease, and particularly in lung cancer, where less than 4% survive in 5 years, patients who have advanced systemic disease. Similarly, there is enough data today suggesting the immune recognition and response in selected tumor types. And this is a list of tumor types, and let me focus on lung cancer, where really there is a strong suggestion of immune recognition through different mechanisms. Immunotherapy is not very new mode of treatment. Actually, is quite old. Started back in 1890 and slowly progressed. And we all remember the treatment with BCG, with interferon, interleukin, the treatment with in prostate, and lately in melanoma, the breakthrough with ipilimumab. What is the characteristic of immunotherapy that make us more hopeful about the treatment of certain patients with cancer? Is the survival plateau following response. Many patients, close to 20%, especially here in melanoma, live for a very long period of time. So immuno-oncology is a fact today and part of our treatment armamentarium. It has been added to surgery, radiation, chemotherapy, target therapy, and immuno-oncology. How immuno-oncology works? We have to activate the T cells to kill the tumor cells. There are tumor antigens released by the tumor cells. These tumor antigens are presented to inactive T cells. T cells are activated and proliferate. The T cells then recognize the tumor antigens. And these T cells, recognizing the tumor cells, kill these tumor cells. This is the basic mechanism. Certainly, in order to have a T cell activated and kill the tumor cells, there is a backup mechanism which is really complex. The regulation of T cell activation is a balance between activating and inhibitory signals. Let me focus on this inhibition and this complex of PD-1 and PD-L1. The PD-1 is the receptor in T cells, and this is the ligand in the tumor cells. And the connection of these two make these tough cells, T cells, inactive, inhibits the activity of T cells. And let's come now to nivolumab, which is one of the most important immunotherapeutic agents. Is a checkpoint inhibitor and anti-PD-1 inhibitor, which nivolumab enters between the PD-1 receptor of the tumor cell and the T cell and blocks this inhibition. Actually, inhibits the inhibition, therefore activates the T cell. This is the basic mechanism for the PD-1 checkpoint. There are several drugs now in research, and the pipeline of several research clinical efforts are on the way. This is a list of some of those. The most important and far advanced in the progress, in the research progress, is the nivolumab, the PD-1 inhibitor pembrolizumab, and the PD-L1 atezolizumab. I will try to focus on nivolumab, from which we have several robust data. Let's start with the phase 3 study, the Checkmate 017 of nivolumab versus docetaxel in previously treated advanced or metastatic squamous cell non-small cell lung cancer. Actually, a second-line treatment in patients with squamous cell carcinoma. This is the design of the study, nivolumab versus docetaxel, in the doses that you see here in the slides. Patients have been treated before with one platinum-based doublet chemotherapy. These are the demographics. I would like just to point the PD-L1 expression percentage, which was under more than 1%, more than 5%, more than 10%, and not quantifiable. This is very important to make some explanations later on. And going directly to the overall survival, you see the impressive results of 1 year overall survival with nivolumab 42% versus 24% with docetaxel. A difference in months 9.2 versus 6, a little bit more than 3 months different in the overall survival. Second line treatment, squamous cell carcinoma. This is the progression-free survival. Again, statistically significant difference between nivolumab and docetaxel, 3.5 months versus 2.8 months, 21% 1 year versus 6.4%. The objective response rate between the two arms was in favor of nivolumab, 20 versus 19, and you see here all the subgroups. It is interesting to notice that the responses, the overall survival, the progression-free survival, was non-related to the expression of PDL biomarker. Even patients with lower than 1% PDL expression had responses. Certainly, the higher the PDL expression, the higher the responses. The quality of life was in favor of nivolumab, as you can see here, compared to docetaxel. And coming to the adverse events, the adverse events were significantly less in the arm of nivolumab, grade 3 and 4, versus docetaxel. You can see here the difference, and we see that in the practice. I would like to focus on pneumonitis, which is one of the side effects that we have to pay attention in immunotherapy, and here was more in patients who received nivolumab and none in patients who received the docetaxel. However, most of this pneumonitis was reversible. It is sometimes quite severe, grade 3 and 4, but this is not the commonest event. So, in summary, from this study, we can summarize that nivolumab is a PD-1 inhibitor that demonstrates survival benefit versus standard of care so far of docetaxel as second-line treatment. 41% reduction of risk of death, 1 year overall survival 42%, median overall survival 9.2 months. Nivolumab benefit is independent of PD-L1 expression. The safety profile is favorable, and we know by now that nivolumab received FDA approval. And this is the article in New England Journal of Medicine that published these results. Let's go to the next equally important study. Again, a phase 3, the same study but in non-squamous non-small cell lung cancer. Similar design, I would like to focus on patients who had EGFR positive mutation and ALK positive translocation status among the patients who received the treatments. Again, the overall survival is in favor of nivolumab. 1 year survival 51% versus 39%. Median overall survival 12.2 months in nivolumab, 9.4 months for docetaxel. Again, all subgroups were favored from the treatment with nivolumab versus docetaxel, except patients who had EGFR mutation. The responses were in favor of nivolumab, 19% versus 12%. And again, it was unrelated to the PD-L1 expression. That means the patient with low PD-L had responses. The treatment-related adverse events were similar. And again, I would like to focus on pneumonitis, which is more common in patients who received nivolumab. Most of the pneumonitis were manageable. So nivolumab, as a PD-1 inhibitor, significantly improved overall survival versus docetaxel as a second-line treatment in patients with non-squamous cell carcinoma. The safety was favorable, and it's right now rather a standard of care for patients with second-line treatment who have to receive second-line treatment. Just to show you a small study in small cell lung cancer in which the interest point is the combination of nivolumab with ipilimumab, a new concept of combining two different checkpoint inhibitors. This is the design, here is the combination, and immediately to show you the results that there is a difference in the combination compared to the monotherapy. Certainly there is increased toxicity in the combination. However, it seems that this is manageable from these small studies. So the safety profile of nivolumab monotherapy and nivolumab ipilimumab are consistent with other tumor types and were managed with established safety guidelines. We have to be a little bit careful treating patients with immune reactions which are a little bit different from what we used to know about side effects from typical standard chemotherapy. Nivolumab monotherapy and nivolumab ipilimumab show activity and durable responses in small cell lung cancer patients who progressed after at least one prior therapy. And this is again regardless of PD-L1 expression. One of the characteristics of these responses and survival is the duration. The response lasts after the initial response. This is patient with lung cancer, and also continues after the discontinuation of the immunotherapy. This is an attractive option for immunotherapy and characteristic of immunotherapy. Well, let's look a little bit about the future. What may the future hold? Immuno-oncology, it has to be evaluated in earlier stages. It has to be evaluated across different cancer types. We have to find biomarkers to predict who is going to respond, who is going to survive longer, because these agents are very expensive. We need to look for novel targets, and we have to evaluate immunotherapy, checkpoint inhibitors with either chemotherapy or radiation therapy or targeted agents or other immuno-oncology agents. Here are just some examples of combining immunotherapy with radiation therapy, with chemotherapy, and with targeted therapy. There is a lot of research going on right now. So we are here now. We have this plateau with immunotherapy, monotherapy, and we are looking forward combining with other agents to increase this gap, to increase this distance, to improve the survival, to make the plateau on higher level and longer. And just coming to the end of this talk, I want to show you some of the studies going on combining different immunotherapeutic agents. Pembrolizumab, as we said, is another anti-PD-1 checkpoint inhibitor combined with the well-known ipilimumab in a phase 1 study in patients who had received multiple lines of treatment. And we have some impressive results. 71% of patients saw decrease in target lesion burden. And here are the colors indicate the different dosage. 2 milligrams pembrolizumab per kilo versus 10 milligrams per kilo. And you see here nicely these responses. So we can conclude that we are at the early beginning of the immunotherapy, the modern immunotherapy. We know by now that we have new agents that are approved and we can use in our patients. We are looking forward for the future to combine these agents, and just showing you this last slide, we can make some progress, taking a lot of attention and being careful about the toxicity, which so far is manageable. Thank you very much.
Thank you for this beautiful, excellent presentation and summary, because this immuno-oncology is now an exciting field of oncology. Thank you, Professor. Any questions or comments from the audience? Please, Professor.
Thank you very much, Professor Kosmidis. My question is about the test used for the PGL1 evaluation. If you go to the checkmate study 017 in squamous cell lung cancer, it did not have any impression, no difference. If you go to the checkmate 57, it may have some in the non-squamous cell carcinoma. If you go to the pembrolizumab study, it is having some, it has an effect predicted for the drugs. And if you go to the atezolizumab, which is the Roche drug, here you see they have done like a tumor cell and an immune cell stratification with the PGL1, and here they find differences, the measured differences between those that were positive from PGL1 versus those that were negative. So the issue is still very controversial. And I think this is the only way is to standardize these tests in order to find a real predictive biomarker for immunotherapy.
I think you're absolutely correct. Just give me the opportunity to make a comment. At the present time, we don't know too much about that. We have to accept it. If we look at the studies between nivolumab and pembrolizumab, we'll see significant difference between the response and survival related to PD-L1 expression. My opinion is that in nivolumab, this is completely unrelated. Certainly, the higher the expression, the better, but you cannot avoid giving this drug because the PD-L is low. In pembrolizumab, however, to my estimation, is more closely related to PD-L1. Certainly, we don't have this experience with many patients, and we have to standardize the method, as you said. I agree.
Yes, please.
Dr. Kosmides, can you please work on the...
Please.
Thank you very much for your excellent comprehensive presentation. But what about the circulating PD-L1? I will go one step forward from Dr. Rabab's question about the positivity or negativity of the PD-L1 in the local tumor specimen. But I will go further to the circulating PD-L1. Do you have any guesses about the possibility of being like the circulating tumor DNA or something? Just to take the drop of blood and search for the PD-L1. What do you think?
I don't think I can tell you more than you know, because there is not any cumulative data so far about the biomarkers, the PD-L1. I think there is a lot of work going on, and I think we have to wait.
Maybe I can just comment on that. There is actually a company who is providing soluble a test for determining the soluble PD-L1 in the plasma. So I think in the next couple of months and years we will hear more about it. So definitely it's a way forward. So the liquid biopsy for PD-L1.
Dr. Medhat Kafari, NCI Cairo. When do you monitor, when do you evaluate the drug? After 1 month, 2 months, or you go straight ahead with the drug until the end? And if there is any difference in immune parameters or so, in responders or non-responders patients in your study?
Right. We must identify first the pseudo-progressors. There are some patients who, following the first couple of doses of immunotherapy, appear some progression, which is not a real progression. It's a type of immune reaction. That's why we have to wait a bit longer than the 2 cycles. I would personally prefer to have a 3rd and 4th cycle in order to identify the responders.
So can I just have one last question? You gave a nice overview of the history of lung cancer treatment, and what I recall is that the targeted agents, the monoclonals, needed chemotherapy to be active. The example of cetuximab and bevacizumab is linked to the administration of chemotherapy. So apparently this is not the case for nivolumab and pembrolizumab. Although I think there's one PD-L1 inhibitor or PD-1 inhibitor, atezolizumab, in which, combination with chemotherapy is perhaps superior. Can you comment on that? What is the possible discrepancy between these findings?
It's an attractive option. I don't know if we have enough data to support this concept, but certainly there are studies now going on with a combination of target treatments and chemotherapies.
If no other questions, I would like to thank Professor Kosmides and to thank the audience, and thank you very much.
Mike.